Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. This is the lecture by Dr. Yasser Serag. My name is Sharif Yousef Emam, and I will be presenting this lecture about retinal vascular disorders. As you know, the retinal vascular disorders are either caused in the form of a local disease related only to the eye, and those include vascular occlusions where there are venous occlusions like the picture on the right, showing a branch retinal vein occlusion involving the macula, or a central retinal vein occlusion which involves the whole retina due to occlusion of the central retinal vein. Other occlusions include artery occlusions, which have very large variance or a large amount of variability according to the area of the retina affected. It can affect the central retinal artery, which causes severe diminution or even loss of vision rapidly within seconds. This is a sudden diminution of vision. It also can affect only a part of the retina, and that is called a branch retinal artery occlusion. There is also a variant of the central retinal artery occlusion where there is a patent ciliary retinal artery, and that patient can have very good central vision, but he has only tubular vision. Both these are local diseases. However, there are some vascular disorders in the retina that are due to or related to systemic diseases. They are characterized by being bilateral, and they are usually symmetrical in both eyes, but sometimes there is variability between the right and the left eye, so sometimes it's asymmetrical. They are secondary to systemic diseases, so the main disease is not present inside the retina but elsewhere in the body, and the retinal problem or the disorder in the retina that we see is related to or secondary to this disease. They are characterized, of course, by retinal vascular changes, and they all of them share hemorrhage and exudate within the retina itself. Some of those systemic diseases include retinopathy of benign hypertension, which is present in a lot of patients, retinopathy of malignant hypertension, renal retinopathy, which is related to renal diseases, retinopathy of toxemia of pregnancy, which is related to the toxemia or the increased blood pressure that happens at the late or the third trimester in pregnancy, and of course the main systemic disease that affects the retina is diabetic retinopathy. As we said, diabetic retinopathy is the main disease that affects, systemic disease that affects the eye and affects all ages. It's not only related to old age, but it also affects young ages. So, as you know, diabetes mellitus is a group of diseases that are characterized by high blood glucose level. It results from the defect in the body ability to produce or use insulin. And there are two types of diabetes mellitus. The first type is type 1, which presents about 5% of the diabetics, and it happens usually in young and children. However, type 2 is the more or the most common form of diabetes. As we said, diabetes mellitus is not a local problem related to a specific country, but it's a global problem. It affects all countries all over the world. However, there is a variability between the incidence of diabetes mellitus in different countries. As you know, diabetes mellitus in developing countries is much higher than developed countries, although the US has a lot of people who have diabetes mellitus. Diabetes, as you can see from this graph, has very high incidence in both the Middle East, North Africa region, which is called the MENA region, and also in South Asia, including Malaysia. The world's incidence of diabetic patients was about 382 million people. That was 2013. However, this incidence has increased to about 425 million people in 2017. The problem is 46% of those are actually undiagnosed. This is only estimates. And if we go back and trace the increase of diabetes mellitus since 2000, we will see that between the year 2000 till the year 2019, the incidence of diabetic retinopathy, diabetes mellitus, has actually tripled or even more than tripled, and is expected to even rise furthermore, and is expected to reach about 700 million people, and that will be about the year 2060. Diabetes mellitus, as we said, there are two types. One of them is type 1 and the other type 2. And in children, most of the diabetic children are actually type 1. However, the incidence is completely inversed in adults, where most of adults who have diabetes are actually type 2 due to obesity or inability of their body to use the insulin, which results in high blood glucose level. Diabetic retinopathy is progressive dysfunction of the retinal blood vessels due to chronic hyperglycemia. It initially is symptomless, but if left untreated, it may progress to low vision and even blindness in some cases, where the advanced changes in the eye can result in complete loss of vision. Diabetic retinopathy is much more common in the insulin-dependent diabetic retinopathy, which is the type 1 diabetes. It represents about, or it's present in about 40% of people who have insulin-dependent diabetes mellitus. However, the incidence is much less in non-insulin-dependent diabetes mellitus or in the type 2. As we said, diabetics have 30%, 35% have some type of diabetic retinopathy. However, 11% of all diabetics have vision-threatening diabetic retinopathy. Diabetic retinopathy actually is based on the fact that diabetes, the high blood glucose level, causes microangiopathy affecting the retinal arterioles, capillaries, and venules, which means it affects mainly the small blood vessels. It causes different changes, including thickening of the basal membrane, endothelial cell damage, RBC changes. The plasticity of the RBCs decreases greatly. That's why they occlude the blood vessels, and of course they cause increase in the platelets thickness, which leads to furthermore vascular occlusion of the small blood vessels. Diabetic retinopathy is always bilateral. You rarely find a patient who has unilateral diabetic retinopathy. However, they may be asymmetrical. So one eye has non-proliferative, something called non-proliferative diabetic retinopathy, and the other eye has proliferative. There may be some difference or a difference between the level of diabetic retinopathy in one eye compared to the other. As we said, diabetic retinopathy is mainly related to the duration of diabetic retinopathy, diabetes mellitus. So most patients or most people who have diabetes mellitus for more than 10 years, they actually have some degree of diabetic retinopathy. However, after 20 years of diabetes mellitus, this is what the study says, after 20 years of diabetes diabetic retinopathy is present in about 99% of insulin-dependent diabetes mellitus patients who are type 1. However, it's only present in about 60% of type 2 diabetes. Risk factors for the occurrence of diabetic retinopathy in diabetic patients include the duration of diabetes mellitus, poor glycemic control, associated diseases like hypertension or renal diseases, hyperlipidemia or high lipid profile in those patients, whether it's the increase in triglycerides or in cholesterol. This can also lead to the progression of diabetic retinopathy in the patients who have diabetes mellitus. As we said, diabetic retinopathy can involve, or many other factors include the family history. Some patients who have family history or more prone or they have their parents who are affected with diabetic retinopathy, they are actually more prone to diabetic retinopathy too. Overweight, unhealthy diet, practical inactivity, increased age also is another factor, high blood pressure. Some ethnicities are more affected by diabetic retinopathy than others, like black people or African Americans, let's say in the US. The history of gestational diabetes, poor nutrition during pregnancy, all these are risk factors for the occurrence of diabetic retinopathy in patients who have diabetes mellitus. The pathogenesis of diabetic retinopathy actually can be divided into two parts. The first part is leakage, and the second part is occlusion. For the first part, the leakage, which means the blood content can pass through what we call the blood-retina barrier. We have two blood-retina barriers in the body or in the eye. One of them is the inner blood-retina barrier, which is formed by the blood vessels and their pericytes surrounding the blood vessels, as well as the tight junctions between the endothelial cells. And the other is the outer retinal blood-retina barrier, which is formed by the Bruch's membrane, as well as the tight junctions between the retinal pigment epithelial cells. So if diabetes leads to breakdown of the inner retinal blood-retinal barrier with pericyte loss, this can lead to leakage of fluid first inside the retina. This fluid has proteins which can lead to foveal exudates or intraretinal exudates, and sometimes the progression of the leakage can increase till reaching the level of hemorrhage or blood going into the retina itself. Not only pericyte loss, but also something called microaneurysm can happen, which is a focal dilatation of the blood vessel, the small blood vessels, the capillaries usually, and it happens due to focal loss of the pericytes and endothelium at this area, so outpouching of the blood vessels can happen. Microaneurysms can be seen during regular fundus examination. Of course, for this fundus examination, we can use either the direct ophthalmoscope, indirect ophthalmoscope, or slit lamp by microscopy, using the slit lamp with the use of adjuvant lenses, auxiliary lenses that can be used to examine the fundus. Of course, the third form, or the slit lamp, is the best method to examine the fundus to detect small or subtle anomalies in the fundus itself. They can also be seen using fluorescein angiography, which is the picture on the right. This shows the blood vessels, the major blood vessels. If you see focal spots of white color, these are usually microaneurysms that have the fluorescein stored inside them, leading to the picture that we call microaneurysms on the fluorescein angiography. Both the breakdown of the blood-brain barrier, pericyte loss, and microaneurysm can lead to macular edema, and this can be seen as we can see in the upper picture, which is similar to the histological picture that we see. The lower picture shows something called the OCT image, which is the optical coherence tomography image, which is an investigation that we can do for diabetic patients to see whether there is edema or not inside the retina. This picture shows that there is intraretinal fluid, which are these black spaces within the retina, as well as some fluid is present beneath the fovea, or the central part of the retina, and this is called a subfoveal neurosensory detachment. Neurosensory detachment is the fluid gathering between the photoreceptors, or the neurosensory retina, and the RPE cells. Not only edema, but sometimes this progresses to exudate and even to hemorrhage, and this can lead to the picture of diabetic retinopathy. We can see this in this picture. This is a color photo exam of the right eye of the patient, showing these reddish spots, which are actually dots of hemorrhage. You can see, it's very difficult on the fundus photo to distinguish between the dots of hemorrhage and the microaneurysms. However, usually the microaneurysms are much smaller than the dots of hemorrhage. Sometimes it's even progressed more, that you can see the yellowish exudates. These are hard exudates, the present in the fovea itself. However, in the upper part of the retina, we can see that there are also some soft exudates, which result from microinfarctions that can happen due to the blood pressure increase that happens together with the diabetes. The same thing we can see here. There are foveal exudates, or the yellowish exudates, present inside the retina itself, as well as dots of hemorrhage that we can see on the fundus photo, and this is of course the right eye of the patient. The second pathogenesis, or the second way that diabetic retinopathy can affect the retina, is occlusion. So the first thing we said that it can affect the retina by leakage. The second form is via occlusion, and because it leads to thickening of the capillary basement membrane, endothelial proliferation, as well as deformation of the RBCs and platelet aggregation, this all can lead to occlusion of the small blood vessels that supply blood to the retina. This will lead to retinal hypoxia. Not only this, the retina responds when it does not have enough blood reaching it. It sends out for help, so it produces some substances called the vasoformative substances, which we can collectively call the VEGF, which is the vascular endothelial growth factors. These are growth factors that are produced by the hypoxic retina to stimulate the growth of blood vessels, so more blood can reach it. This can lead to neovascularization, or abnormal neovascularization, abnormal blood vessels forming inside the retina, which are different than the main blood vessels of the retina, that they are very thin, they are arborizing, or they branch a lot, and they are very weak. That's why they can rapidly or easily rupture, leading to vitreous hemorrhage or subhyaloid hemorrhage. So this is the pathogenesis of the diabetic retinopathy. We can see that there is endothelial damage and proliferation, capillary basement membrane thickening, increased plasma viscosity and deformation of the RPCs, as well as increased platelet thickness, and this can lead to decreased capillary blood flow and perfusion, leading to retinal hypoxia. The hypoxic retina can form either arteriovenous shunts, or AV shunts, or intraretinal microangiopathies, which are short. They can be called short as IRMA, and the cotton wool spots. They can also lead to formation of VEGF, which is the vascular endothelial growth factor, and this can lead to formation of new vessels or new vascularization, whether they are at the disc, which are called NVDs, or new vascularization at the disc, whether elsewhere outside the disc, which are called NVEs. Sometimes they can form on the iris itself, leading to something called rubiosis iridis, and they even can form in the angle of the anterior chamber. This can lead to the formation of, or the occurrence of, a neovascular glaucoma, which is one of the late end stage forms or stages of diabetic retinopathy. Fluorescein angiography, this is a picture of fluorescein, can show easily the areas that do not have enough blood. This area here, temporal to the macula or temporal to the fovea, does not have enough blood, as well as different other findings that can be seen, like microaneurysms, intraretinal microangiopathies. All this can be seen easily by fluorescein angiography. Not only the central part, but also when examining the peripheral part of the retina. So as we can see here, this is a wide field view of the retina itself, so showing large areas of ischemia in the periphery. Although the center has good blood supply, however, the peripheral retina does have large areas of ischemia. We can also see some NVEs or new vascularization elsewhere along the upper nasal arcades. There are some laser scars, meaning this patient has received some form of treatment in the form of laser, and that's present on the left side of the photo. These rounded or nearly rounded spots are actually laser scars. If the ischemia involves the macula, the vision can greatly be affected. So if the patient has macular edema, this can be treated. If he has leakage, it can be treated, and control of blood sugar can help with the resolution of the macular edema. However, if there is macular ischemia, meaning that the blood vessels that supply the macula with the blood have been occluded due to diabetes, this is a very grave and very late condition that can greatly affect the vision, and unfortunately does not have any treatments. If the blood supply of the retina or if the macular area is affected, you cannot do laser for the macula, and it will not improve vision. To be able to see if the macula is affected or not, you can either do the fluorescein angiography, like the picture on the left right here, or you can do a new modality or new testing modality, which is called OCT angiography, or optical coherence tomography angiography, which is a non-invasive method. You do not need to inject a dye inside the arm of the patient like the fluorescein. However, you can use a non-invasive method to assess the blood supply reaching the macular area with a test called OCTA, or optical coherence tomography angiography. These are two photos. One of them is the color photo on the right and the fluorescein angiography photo on the left, showing the IRMA, or intraretinal microangiopathies, that can happen due to ischemic changes happening in diabetic patients, and also new vascularization or abnormal blood vessels. This is a color photo of the right eye, showing NVDs, present at the disc. These are fine arborizing or branching vessels that can cover the optic disc. This is called NVDs, and they can also be seen temporal to the macula, and these are called NVEs. They are elevated, they are very thin, they are fenestrated, they anastomose or arborize, and they can easily rupture, leading to retinal and vitreous hemorrhage, tractional detachment in late stages. This is the same thing. The left photo shows the abnormal vessels at the disc, which are called NVDs, and the right photo shows abnormal vessels elsewhere, or any area that is outside the disc, and these are called NVEs. This is the same picture of the same patient, showing the color photo on the left side, showing the abnormal blood vessels covering the disc, as well as the fluorescein angiography of the left eye, showing the leakage that happens on the fluorescein due to the presence of NVDs. A similar picture also. However, this eye is different actually. So we have NVDs present on the color photo, and NVDs also showing on the fluorescein, which is present to the right. However, this patient has been treated. We can see these black spots covering the area temporal to the fundus, as well as the area of the retina below the macula, and these are laser scars. This is also another wide field view of the central part of the fundus of the patient. We can see the macula in the middle. There are NVDs covering the disc. There are NVEs elsewhere, and this is, of course, a late stage of diabetic retinopathy. Sometimes it happens at the edge of the iris in the front of the eye. So these are called rubiosis iridis. Sometimes they can happen in the angle of the anterior chamber, and this of course cannot be seen with regular slit lamp examination. You have to use a special lens, which is called the gonio lens, to be able to see the angle of the anterior chamber. And you can see right here that there are small are reddish small blood vessels in the angle of the anterior chamber, and these can interfere or impair the outflow of aqueous, and this can lead to increase in the intraocular pressure, which can lead to neovascular glaucoma. Diabetic retinopathy can be classified into two main stages, either non-proliferative or proliferative, according to whether there are new vessels or there are no new vessels. So if the diabetic changes do not involve the happening or the occurrence of NVDs and MVEs, this is called a non-proliferative diabetic retinopathy, and these can be further classified into a mild, moderate, and severe degrees. However, if blood vessels happen inside the retina, whether they are NVDs or NVEs, they are called proliferative diabetic retinopathy, and this can be further divided into a high risk, a regular proliferative diabetic retinopathy, a high risk variant, or an advanced stage of diabetic retinopathy. The mild non-proliferative diabetic retinopathy is characterized by the presence of only microaneurysms, which are the small reddish dots you can see on the fundus examination. Fluorescein can easily show the presence of these microaneurysms as the whitish dots that can be seen in the fundus. Further changes in the retina can change the classification from mild to moderate, with the presence of retinal hemorrhage, cotton wool spots, venous dilation, beading of the blood vessels or the veins of the retina, and even the occurrence of ERMAs or intraretinal microangiopathies that are limited to two quadrants of the retina. If we divide the retina into four quadrants, then if the changes are limited to only two quadrants, this is called moderate non-proliferative diabetic retinopathy. However, if they involve more than that, they are called this is the picture showing the venous beading. As you can see, the vein itself is constricted and dilated like beads, like a string of beads, and this is called the venous beading. The same can be seen here in the fluorescein angiography, showing the vein itself having beads inside the vein, multiple areas of constriction and then dilation. This is called the venous beading. The venous looping can be seen in the upper picture in the color fundus photo, and the lower picture showing the fluorescein of this patient, showing the loop that happens along the vein, and this is called venous looping. This is another sign of diabetic changes. However, if the changes that include the microaneurysms, retinal hemorrhage, cotton wool spots, venous dilation, or beading, and retinal microangiopathies are present in more than two quadrants, this is called severe non-proliferative retinopathy, and we can also easily remember this by something called a 4-2-1 rule, meaning that severe NPDR or non-proliferative retinopathy can either have at least more than 20 microaneurysms in each of the four quadrants, or definite venous beading in at least two quadrants, or prominent ERMAs or intraretinal microangiopathies in at least one quadrant. If you have any one of these two, either the four quadrants having microaneurysms, two quadrants having venous beading, or one quadrant having prominent ERMAs, this is a severe non-proliferative retinopathy patient or severe NPDR patients. On the contrary, the proliferative changes that can be seen in the fundus, this is a fundus fluorescein angiography showing the presence of NVEs, which are new vessels elsewhere, not in the disc but elsewhere. This is a proliferative diabetic retinopathy patient. Sometimes the changes can happen on the disc itself, as in the photo on the left side, showing the disc, the optic disc, as well as some small vessels on the optic disc itself. These are NVDs, and they can also be seen on the fundus photo, showing also the NVEs or the new vessels elsewhere. The proliferative diabetic retinopathy or PDR patient can further be classified into a regular PDR, a high-risk PDR, which includes the presence of NVDs or NVEs with vitreous hemorrhage, NVDs covering at least half the disc or half the disc diameter or half the optic disc. These are high-risk proliferative patients, like this patient having a pre-retinal hemorrhage area as well as new vessels covering most of the disc. Right here we can see there are large areas of NVDs covering the disc. This is a high-risk PDR patient. However, if the patient has even furthermore damage to the retina, including tractional retinal detachment, or dense vitreous or subhyaloid hemorrhage, this is an advanced PDR patient, which in most cases requires surgical intervention. This is a patient who has large areas of hemorrhage covering the retina. The asterisk or the star is showing a area with a pre-macular hemorrhage covering the fovea itself, so this patient does not have central vision. Sometimes there are membranes covering or encircling the macula, so these are tractional membranes covering the central part of the fundus, and the patient in these cases is usually or has usually visual affection. The vision is affected in diabetic retinopathy either by traction, which means that the vision, the macular itself is pulled, leading to tractional attachments. It can also be affected if there is ischemia, as we mentioned before, that meaning that the blood supply of the retina does not reach the macula properly, or sometimes it can lead to diabetic macular edema, which means that the fluid accumulates inside the retina, affecting the function of the macula itself, and this will lead to decreased vision. Diabetic macular edema can be classified into focal, which means it only affects a small portion of the macula, or sometimes it's diffuse, so it affects a large area of the macula, or sometimes it's diabetic macular ischemia, as we mentioned, which means that the macula does not have enough blood reaching it, and sometimes it can be it can be mixed, meaning it involves ischemia or ischemic changes to the macula as well as edema to the macula, and this of course is one of the worst findings that you can see in a diabetic patient with impaired vision. How do you manage a patient with diabetic retinopathy? Of course, the primary prevention is prevention of the disease itself or of the progression of the patient to diabetic retinopathy by strict glycemic control, blood pressure control, as well as any other diseases in the eye or in the body. Secondary prevention is by routine eye examination. You should always examine the patient. A patient who has diabetic retinopathy you should not wait till the diabetic retinopathy happens. But if a patient who has diabetes, it's more than 5 years, you should examine this patient. Even the guidelines say that if a patient is recently discovered diabetic, some patients have diabetes for a long time and they do not discover that they are diabetic except late in the disease. If something happens to their body, whether their eye or their kidney or elsewhere, and they suddenly discover that diabetic, thinking that they have been only diabetic since a couple of months. Actually, they have been diabetic since years, and they did not discover diabetes properly. So most guidelines say that if you have a patient who has recently been diagnosed as a diabetic patient, you should have a routine eye examination for him, and according to this examination, you can have follow-up examinations later on. Tertiary prevention include treatment of the disease that has already affected the retina, and this can either be retinal laser photocoagulation or in sometimes surgical intervention is needed, so the patient needs to have vitrectomy, removing any vitreous hemorrhage or tractional attachment that he can have. How to diagnose retinopathy? Fundus examination, of course, is one of the very important steps that you can do during regular fundus examination. However, if you need further investigation, you can do a fluorescein angiography, a fundus fluorescein angiography. We can see here that the patient has a cannula in his arm. The doctor is injecting, or the nurse is injecting fluorescein, which is a special dye that we use in ophthalmology, intravenously. And then we can, using a special fundus camera, we can use the fundus camera to photograph the blood vessels of this patient with the fluorescein inside them. The blood vessels normally have fluorescein, so they actually appear white on the fundus photo or the fluorescein photo. If there are abnormal findings in the fluorescein, whether hypofluorescence or hyperfluorescence, this is a special topic that I think will be discussed in the morning rounds. You can discover whether the patient has actually problems in his retina or not. So the fluorescein angiography can diagnose macular edema. They can detect the presence of neovascularization, and if there are any areas of ischemia that are devoid or do not have enough blood supply reaching them, whether in the macular area or outside the macula, they can easily be detected by fluorescein angiography. Optical coherence tomography is another test that we can use also to detect the presence of macular edema in the central area of the fundus. We can quantify macular thickness and the presence of edema. This is a fundus, this is an OCT or optical coherence tomography image showing the presence of macular edema or intraretinal fluid inside the macula as well as beneath the macula. This is what we call the subfoveal neurosensory detachment. And in the lower left corner, we can see there's a map showing the actual thickness or the average thickness of the macula in different areas of the fundus, and this is very easy, very good to be able to follow up this patient and see the effectiveness of any treatment that is given. Most new machines can also not only give you a numerical thickness of the retina, but also can even give you a 3D image showing if there are any traction areas. It's like looking to the retina in 3D. So if I'm going to have to do any surgical intervention for this patient, I can easily know the areas of focal traction, where is the retina attached to the posterior hyaloid or to the vitreous or the membranes, and this can help me greatly when I'm planning to do the surgical intervention of this patient. As we mentioned, the follow-up for diabetic patients, there is a scheme or a schedule. The recommended eye examination according to the duration of diabetes, the type of diabetes also affects, and whether this patient is pregnant or not. So if a patient who has type 1 diabetes, the first examination should be about 3 to 5 years after diagnosis, but as we said, most patients do not discover that they are diabetics except accidentally. So my personal regimen is to examine the patient at their diagnosis, because sometimes, as we said, a patient may have diabetes since a long time and he did not know except accidentally or by luck or even by chance. After this first examination, he should be, or the patient should be examined at least annually. The type 2 patient should be examined at time of diagnosis. Then this should be followed by an annual examination. And of course, if a patient who has pregnancy and has type 1 or type 2, she should be examined before conception, before she's trying to get pregnant, and early in the first trimester. If there is no changes, if the no changes can be seen in the fundus of this patient, then you can have examination every 3 to 12 months. And if the patient has actual changes or even severe changes in the fundus, it should be examined maybe even every month or every 3 months. Medical treatment of retinopathy is very important. You should control the metabolic condition, control of hypertension, control of blood lipids, as well as aspirin can help to decrease the platelet aggregation, thus decreasing the ischemic changes that can happen in the retina. Regarding the ophthalmology or diabetic retinopathy, when we are trying to treat a patient who has actual diabetic retinopathy, in addition to all the things that we said before, you can apply something called laser photocoagulation, whether it's focal laser, which we are attempting to close the microaneurysms. Sometimes we do a grid laser for patients who have diffuse macular edema to enhance the ability of the RPE function or RPE cells to push the fluid out into the choroid. And in some patients, we have to do a pan-retinal photocoagulation, which stands or which PRP stands for. PRP or pan-retinal photocoagulation is a special type or a special technique using the laser photocoagulation, which we use in patients who have proliferative diabetic retinopathy or PDR. This treatment aims to destroy or ablate the ischemic retina, thus preventing the release of the vasoformative substances, which can lead to the formation of the new vessels, which furthermore can lead to the occurrence, whether that's vitreous hemorrhage, subhyaloid hemorrhage, tractional detachment, or neovascular glaucoma. This photo shows a patient who had pan-retinal photocoagulation. This is, of course, a fundus photo of the left eye, showing the macula in the middle. Then we have these whitish spots present outside the macula. This is pan-retinal photocoagulation. However, in this patient, we can see in the lower left area that there are still some NVEs or new vessels present in the lower nasal area, and these need to be further treated. Not only laser, until maybe about 50 years ago, laser or 30 years ago, laser was the mainstay or the main method of treatment for patients who had diabetic retinopathy. However, currently we can inject various substances inside the eye to decrease macular edema and decrease the instance or release of VEGF materials. One of the first treatments that we had was steroids. We usually, or we had for a while or for a bit of time, we injected steroids inside the eye. The main steroid that we use to inject inside the eye in patients who have diabetic agents is called triamcinolone acetonide, which strengthens the blood-retina barrier before PRP. However, of course, since it's a steroid, it has side effects including secondary glaucoma and cataract. Sometimes it may lead to endophthalmitis and retinal detachment if it rarely happens, but it sometimes happens. Currently, the main drugs that we use for treating diabetic changes or diabetic retinopathy is anti-VEGF or anti-VEGF or anti-vascular anterior growth factor, and these can be used for the treatment of diabetic macular edema and for the treatment of proliferative diabetic retinopathy, the NVDs and NVEs, whether it's before the laser or instead of the laser. And we have three currently FDA approved. There's actually a fourth one, but we don't need to say about that. We not need to talk about that. These are the three currently used. I'm sorry, the last two are only FDA approved. Bevacizumab, or its trade name is Avastin, ranibizumab, and its trade name is Lucentis, and aflibercept, which in the market is called Eylea. These are the three anti-VEGF agents that are currently used for managing diabetic macular edema. In rare instances, the patient has advanced diabetic eye disease, which leads to vitreous hemorrhage and tractional attachments, and the only treatment for those patients, if the vision is affected, is pars plana vitrectomy, which is the surgical intervention. We remove the vitreous and any tractions on the retina itself, pulling on the retina, and this can be used in patients who have vitreous hemorrhage, whether it's persistent or recurrent, premacular hemorrhage, and in patients who have traction retinal attachment threatening or involving a macula. Diabetic pars plana vitrectomy may be the only solution for those patients. The second disease that we're planning to talk about shortly is retinopathy of benign hypertension. So blood pressure above 140 over 90 and currently even less than that, 130 over 90 is currently considered to be hypertension. You cannot say that the patient is hypertensive if you measure him once, because some people who have continuous stress or sympathetic stimulation can have increased blood pressure. However, you should consider measuring the patient multiple times and, of course, in a resting state before deeming this patient has hypertension. Some of the findings that we see in retinopathy of benign hypertension include the arterial narrowing, whether it's focal or diffuse. AV crossing changes can also be seen, and these have different findings, or you can see different forms of the AV crossing changes. As we know, usually the artery crosses above the vein in the same adventitial sheath. So sometimes if the artery is thickened due to benign hypertension, there can be concealment of the vein, meaning that the artery does not show the vein anymore. Usually the artery is transparent, so you can see the vein over the artery. You can see the vein although the artery is moving above it. If the artery shadows the vein or does not show the vein, this is called concealment of the vein. Nicking, and this is called gun sign, meaning that the vein before the artery becomes tapered. Banking and deflection, whether it's an S deflection or Z deflection. These are different signs that we can see during fundus examination of a patient who has retinopathy of benign hypertension. Also, retinal hemorrhage, and they are usually flame-shaped superficial hemorrhage because they happen in the superficial nerve fiber layer. However, sometimes also blot hemorrhage or dot and blot hemorrhage can happen in a patient who has benign hypertension. And of course, exudate can also be seen. Star-shaped exudate in the macula is a hallmark or one of the characteristic changes that can be seen in benign hypertension. It usually means that the patient has very, very high blood pressure and he needs to urgently treat it. The third disease is retinopathy of malignant hypertension and renal hypertension. Renal disease can lead to increase of blood pressure. This is, of course, not sight-threatening, it's life-threatening. It leads to sudden marked increase of blood pressure and usually happens in young patients. The blood pressure can be very high, 280 or even higher, and the same findings that can be seen in the regular hypertension, the benign hypertension, can also be seen in the malignant hypertension. However, they are greatly exaggerated. So there are spasm of the blood vessels, there is hemorrhage covering the fundus, cotton wool spots and soft exudate covering the fundus itself. Hard exudate, macular star can be seen in retinal edema. Even optic disc edema can also be seen in patients who have hypertensive changes due to malignant hypertension. Retinopathy of toxemia of pregnancy. This is a special variant or a special type of malignant hypertension that happens during pregnancy, usually in the third trimester. It's characterized by marked increase of the blood pressure. It is usually associated with leg edema. The female patient, of course, complains of leg edema as well as proteinuria in the urine analysis. They have bilateral retinal findings, include generalized spasm of the large retinal blood vessels, soft exudate covering the retina, hard exudate leading to a macular star, which is the position of the hard exudate within the Henle layer, which is the outer plexiform layer around the retina, or around, I'm sorry, the fovea, that is horizontally oriented. Retinal edema can also be seen, and it may be so severe that it leads to retinal detachment. This is a form of exudate retinal detachment, not tractional, not rhegmatogenous. It's an exudate retinal detachment that can resolve spontaneously once we control the blood pressure. It can also lead to optic disc edema, and as you may know later on, happening or occurrence of the toxemia of pregnancy in the eye, retinopathy of toxemia of pregnancy, is one of the indications for termination of pregnancy. So if the patient is in the third trimester and she has toxemia or has retinopathy of prematurity, and she goes into something called eclampsia, meaning that there are convulsions or even preeclampsia, termination of pregnancy may be considered by the OBGYN doctor, the obstetrician that she's following up with. We can see here the photos of both the right eye and the left eye of the patient showing retinal detachment. This is an exudate retinal detachment of both her eyes, and the vision may markedly be deteriorated. The last entity or variant of retinopathy due to systemic disease is the retinopathy of prematurity, or it's shortened as ROP, or retinopathy of prematurity. Different names were given to this disease before. The most common name was retrolental fibroplasia. However, this name is not used anymore. The main name for this disease right now is retinopathy of prematurity. It happens in preterm and low-weight infants. So you rarely see this, you never see this in adults, but it usually happens in infants. You see the effects if this patient is affected by, or this infant is affected by it. You can see it as an adult who has no vision in this eye, or limited vision in this eye. It happens when the children not are born prematurely, but unfortunately they go into an incubator and they are exposed to excessive oxygen levels. This leads to suppression of the normal VEGF that is produced in these children to help in continuing the vasculature of the retina. So the excessive oxygen leads to suppression of the normal VEGF. However, when the child leaves the incubator and is not exposed to this very high level of oxygen, it leads to sudden compensatory overexpression of VEGF, and this is not limited at the normal formation of blood vessels, but it's switch to the other side, and it leads to excessive formation of the blood vessels, leading to the problem of retinopathy of prematurity. It had different stages. The first stage is called the demarcation line, which is the line differentiating the avascular retina, that retina that is not supplied by any blood vessels, between the avascular retina and the vascularized retina. Gradually, a ridge is formed, which means an elevated area that has fibrovascular blood vessels happens at this junction. Then an extraretinal fibrovascular proliferation happens. This is the third stage. This may be followed by retinal detachment, and this is the fourth stage, and this may be a subtotal or total retinal detachment. And of course, these patients have very poor prognosis. The only treatment for the stage 4 and even the stage 3 sometimes is surgical intervention, and these patients need to be treated as early as possible once discovered. However, the prognosis of these patients, these children or these infants, is usually very poor. Hopefully we discussed most of the topics that you need to hear today, and thank you very much. Hopefully you do well. Thank you very much.